Good afternoon, everyone, and mabuhay. Greetings from Philadelphia. We have very nice weather here in Philadelphia. It's sunny and 80 degrees. I'm Dr. Romel Rivera, the president of the Association of Philippine Physicians in America, one of the organizers of the Filipino-American Health Forum on COVID-19. Before I proceed, I want to acknowledge the presence of our Consul General in New York, who will say a few words shortly. Today, as part of our ongoing webinars on COVID-19, we present series number 6, Multisystem Inflammatory Syndrome in Children, ISC, otherwise known as Pediatric Multisystem Inflammatory Syndrome, PMIS. So the organizers of the Filipino-American Health Forum, as in previous forums, invited a Filipino pediatric infectious disease specialist from New York to educate us and our communities on this rare but nonetheless important COVID-19 related illness in children. We hope that the attendees of today's webinar would be able to spread the word around to your families, friends, and networks. As the saying goes, we are all in this together. Translated to Filipino, bayanihan spirit. We help each other. We take care of our own people, our kapwa Filipino. We educate our own people using Filipino expertise. Our way of empowering Filipino-American community. I will be your MC today, and at this time, I will call on my co-organizers to say a few words. First, I want to call on Dr. Marie Ortaliz, the president of the PNA New York. Marie?
Hello, thank you, Dr. Romel Rivera. Hello, everyone. Good afternoon. I'm Dr. Marie Ortaliz, President of the Philippine Nurses Association of New York. The organization's mission is to unite Filipino-American nurses in the state of New York as a professional group and provide the highest standards of professional practice through education, research, and community outreach. PNA collaborates with professional organizations to provide projects such as this, which impacts greatly on public good. We also participate in the All of Us research along with the Asian Pacific Islander Health Forum through the National Institute of Health to build one of the most diverse databases in history and investigate diseases that affect Asian Americans, such as hypertension and diabetes. Today's series in this virtual forum will enlighten the public and all the parents of the new and extremely rare disease known as multisystem inflammatory syndrome in children in order to know what the red flags are before they go for admission and treatment. An increased awareness of its physiology and treatment will save lives. What is medical science informing us about multisystem inflammatory syndrome in children? You are about to find out. Now we have Dr. Emerson Iya, Chair of Kalusugan Coalition.
My name is Emerson Iya. I'm the chair of Kalusugan Coalition. Kalusugan Coalition is a community organization dedicated to advancing the health and well-being of Filipino Americans. Kalusugan Coalition is very pleased to co-host and to co-organize this truly collaborative effort with a primary goal to educate and empower the Filipino community. We bring you every week the latest information on timely topics about COVID-19, such as this baffling condition among children. The pediatric multisystem inflammatory syndrome captured the news headlines in the past weeks, and we are lucky to have an expert in our midst, Dr. Sy, who will provide evidence-based information about this topic. We thank you for your participation, and we look forward to your questions and comments during our Q&A session. It is now my pleasure to introduce Dr. Laura Garcia, the chair of the National Federation of Filipino American Associations, NAFA New York chapter.
Thank you, Dr. Emerson. Hello, my name is Laura Garcia. I am the state chair for NAFA New York. NAFA's mission is to promote the welfare and well-being of Filipino Americans throughout the United States. NAFA partners with local affiliate organizations and national coalitions in advocating for issues of common concern. Health is a common concern, especially in our environment of COVID-19. With you in mind, this Health Forum was designed. So welcome to our 6th series of Health Forum. Now I'd like to introduce to you Dr. Angelica Razon. Dr. Razon is the committee co-chair of the Council for Young Filipino American Physicians of APPA.
Thank you and good afternoon. My name is Angelica Razon and I'm one of the co-chairs for the Council for Young Filipino American Physicians. As a part of APPA, CFAP's vision is to amplify the voices of our members, patients, and community and inspire every Filipino American medical student, trainee, and physician to be an effective change agent in the community's most pressing health priorities. Now I'd like to introduce my co-chair, Dr. Antonio Moya.
Hello, everyone. My name is Antonio Moya. I'm a neurologist working in Los Angeles. And with the Council of Young Filipino American Physicians, we really encourage young Filipino medical students, residents, fellows, and attendings to gain leadership in our community.
Now at this time, I'm honored and privileged to present to you the Consul General of the Philippine Consulate General in New York, Ambassador Claro Cristobal, who is a great supporter and a partner of the Filipino American Health Forum. The Consulate General in New York shares this series live through the Consulate's Facebook page. Please share the Consulate page. Without further ado, Ambassador Cristobal.
Thank you so much, Dr. Ramel. And all I wish to do now is to again thank all the organizers of this very important health forum. You, I believe, know that New York State and the New York City are both on track to fully reopen the state of New York, and more particularly the last of the 10 regions of the state, which is New York City, beginning June 8th. Now, this is great news and very important news to our kababayans, because we also intend to reopen the consulate on that day, 9 days from now. But it is a sign that our children may go back to school perhaps in the fall. And it is in that light that today's forum is so very, very important to guide our kababayan parents on this very, very rare but very, very deleterious syndrome. So thank you, Dr. C, for joining us today, and thank you all for continuing with this great work.
I now call on Dr. Angelica Razon to tell us about medical disclaimers and housekeeping rules. Dr. Razon.
Our goal for this series is to build community and share information. If you or a loved one is having a specific medical concern, please seek attention from your healthcare provider. This is an evolving phenomenon, and every locality situation is different. Please refer to cdc.gov, coronavirus.gov, and your local public health department for the most up-to-date information. Again, links will be in the chat box and will also be provided in the YouTube description. Now I have the pleasure of introducing our guest speaker, my fellow pediatric physician colleague, Dr. Sharlene Sy. Dr. Sy is a pediatric infectious disease fellow at the Children's Hospital of Montefiore, the pediatric hospital for Albert Einstein College of Medicine. She served as Assistant Chief Resident in her pediatric residency training in the Philippines at St. Luke's Medical Center in Quezon City. She has also served as Chief Resident in pediatric residency training in the US at Flushing Hospital Medical Center, New York. She is certified by the American Board of Pediatrics and is a member of the American Academy of Pediatrics, as well as the Philippine Pediatric Society. She is also a registered medical technologist in the Philippines. Thank you so much, Dr. Sy, for joining us today and sharing your expertise.
Thank you so much, Dr. Razon. Thank you, everyone. Good afternoon. Magandang umaga po sa mga kababayan natin sa Pilipinas. Nagising pa po. So I'm here to talk about COVID-19 and children and this new phenomenon called MIS-C. So I'll first, we all know that this is a rapidly evolving situation and that information may change as it becomes available. So the information I'm going to share here is based on the COVID-19 healthcare provider update as of May 22nd. So the outline, I'll be discussing a basic of virology, COVID-19 in children, and its current US data based on our registry, and what is MIS-C, what we know so far about the treatment and prognosis, and some take-home points for our providers here in the US and for our parents watching. So coronaviruses are important human and animal pathogens. They cause zoonotic infections in birds and mammals, but in the last few decades, they have shown to be capable of infecting humans as well. The outbreak of SARS in 2003 and MERS in 2012 demonstrated the lethality of coronaviruses when they cross the species from animals to humans. There are a large group of viruses that cause illnesses ranging from common colds to more severe diseases. This is a picture of the virus. It is a single-stranded RNA virus and has an envelope. So I emphasize the presence of an envelope because this is the envelope is very susceptible to alcoholic agents and to hand washing. That is the reason why we emphasize as one of the preventive measures of transmission of COVID-19 is to do proper hand washing. There have been 3 novel agents that has caused significant mortality in humans. This will be the SARS-CoV-1 way back in 2002, the MERS-CoV, and currently the SARS-CoV-2, which is causing the infection called COVID-19. So SARS-CoV-1 and SARS-CoV-2 share the same receptor, which is called the human ACE receptor. So, for example, this is the part of the lungs or heart and the intestines, which this receptor is most commonly seen. And this is the spike protein of the virus, which gives its name because it looks like a crown or a halo, the coronavirus. So that is where the virus enters the host. So as of yesterday, there were approximately 5.8 million people worldwide confirmed cases of COVID-19, and we have like 363,000 deaths with a case fatality of 6%. So COVID-19 in children, so all ages are at risk for COVID-19. Majority have milder symptoms and complications appear to be less. And they have the same symptoms as in adults, and they appear between 2 to 14 days after exposure to the virus. The list here is not complete. It does not include all possible symptoms since the CDC will continue to update this list as we learn more about the COVID-19 infection. So as you can see, there is cough, shortness of breath, diarrhea, vomiting, heart involvement, because this is where the receptors are present. There are a few cases of COVID-19 among children. There are reported cases in the US, there are approximately 1.7%. In Italy, there is 1.2%, in Spain, 0.8%, and in China, 2.2%. Of the 70% of the 1.7% of the US, this is coming majority from the New York City, the New York State, and New Jersey. So this is the current US data based from the St. Jude Children's Hospital Registry. So as of May 27, we already have 1,139 cases of confirmed COVID positive cases in children. There are 4 deaths within the first 7 days of hospital stay. So when it comes to age, the most affected children are between 12 to less than 18 years old. They comprise 29%, followed by less than 2 years old, which they comprise as 26%, and 23% for 18 to less than 21 years old. When it comes to gender, it's equally distributed, 50 to 50% between males and females. Ethnicity, it reflects the adult data, wherein majority that are affected are Latino and Black American children. And the exposure risk, most children got it from household contact with known infected persons. And the test was done through a nasopharyngeal swab. Based on this registry, the top 5 symptoms within the first 3 days prior to diagnosis were fever, cough, abdominal pain, weakness, headache, and runny nose. When it comes to treatment, majority didn't receive any treatment. Majority also did not receive steroids. When it comes to outcomes, out of 1,139 reported cases, 77% were managed at home, 88% had mild illness, meaning they did not need any oxygen supplementation, and only 32% were admitted in the ICU, and 68% were managed at the regular floor. Since the disease is rapidly evolving, so what is MIC? It is a rare phenomenon that emerged recently in children, which has been temporarily associated with COVID-19. So we've heard several names: PMIS, MISC, post-COVID syndrome. So they're all the same. It's just that in the United States, it has been officially termed as multisystemic inflammatory syndrome in children, whereas in the Europe and UK, they call it as pediatric multisystem inflammatory syndrome, temporarily associated with SARS-CoV-2 infection. This all started when providers in the UK reported a newly recognized syndrome in late April 27, 2020, which showed overlapping features of Kawasaki disease and toxic shock syndrome, and many tested positive for COVID-19. And then the New York City Health Department first reported the syndrome on May 4, approximately 1 month after the COVID peak. At that point, they referred to it as the pediatric multisystem inflammatory disease. And then on May 14, the CDC issued a health alert and coined the term multisystemic inflammatory syndrome. So let me backtrack first, because I've been talking about Kawasaki disease. So what is Kawasaki disease? This was first reported in Japan 50 years ago, and the cause is still unknown, but it is the leading cause of acquired heart disease in children in developed countries. And it leads to coronary artery aneurysms or dilatation of your coronaries in approximately 25% of untreated cases. So since the etiology or the cause of this Kawasaki disease is unknown, doctors need a certain criteria based on the signs and symptoms of children in order to diagnose Kawasaki disease. To make things more complicated, there are children who meet the full criteria, and there are also certain children who does not meet the full criteria. So there has to be the presence of fever at least 5 days without any other explanation, combined with at least 4 of the 5 criteria, which is shown here in the picture, such as eye redness, or what we call as conjunctivitis with no eye discharge, changes in the mouth, such as the lips, cracked lips, very red, strawberry tongue, wherein the taste buds are prominent, redness of the palms and soles, swelling of the palms and of the hands and feet, presence of neck swelling, which is the enlarged lymph nodes, which is only affecting one side, and any form of rash except the rash that you see in chicken pox. So if the child does not meet this full criteria, then it will be incomplete. Then the doctors will order several lab tests to determine if the patient can be considered as a case of incomplete Kawasaki. There is a journal reported in The Lancet, published by an Italian doctor, termed as an outbreak of severe Kawasaki-like disease at the Italian epicenter of Bergamo during the SARS-CoV-2 epidemic. So what he did was that they noticed that there was a 30-fold increase in the incidence of Kawasaki disease during the COVID-19 pandemic. So they look back into their system 5 years before the COVID pandemic, from January 2015 to February 2020. They look back at the number of cases of Kawasaki disease, and for 5 years, they only saw 19 patients, whereas during the course of the COVID-19 pandemic, which was from their study started from February 18 to April 20, they already saw 10. So there was a 30-fold increase of incidence from 0.3 to 10 per month. The age of onset was that usually the Kawasaki disease are seen in children 6 months to 6 years old, but during the COVID pandemic, they were seeing a mean age of 7.5-year-old children to adolescent. They were also seeing a lot of children with heart abnormality, wherein they had some abnormal echocardiography. 60% in children during the COVID pandemic, whereas 10% only pre-pandemic. And 50% of children presented with shock or decreased blood pressure during the time of the pandemic also. So that's why they reported this in order for us, other countries who has the epidemic of COVID-19 after them, in order to have heightened awareness. So the CDC published an interim case definition of MIS-C. So it should be any individual less than 21 years old with fever for 24 hours or report a subjective fever lasting more than 24 hours, evidence of inflammation, clinically severe illness requiring hospitalization, and with more than 2 or more organ involvement, such as the heart, the kidneys, the lungs, the presence of gastrointestinal diseases or dermatological or neurologic diseases. There should be no other possible causes of this illness, and there should be a documented positive SARS-CoV-2 infection based on the PCR or the polymerase chain reaction, or like the swab, or positive antibody testing. So they have additional comments also, which says that some individuals may fulfill the full or partial criteria for Kawasaki disease, and this should be reported if they meet the MIS-C definition. And if there is any pediatric death with evidence of SARS-CoV-2 infection, it should be considered as MIS-C. So clearly, this is like a spectrum of illness, wherein majority of children will present with fever and inflammation, and then a small subset will present with Kawasaki-like disease, and then a very small subset of children will present with shock requiring ICU admission. So when it comes to the pathogenesis or the cause of this, there is still a lot of unknowns, but the hypothesis is that if there is an infection, it will trigger or activate the immune system, and the body will go into an inflammatory state. But then, if there is excessive activation of the immune system, it becomes uncontrolled to the point that it becomes very dangerous, or it has an exaggerated response that is no longer safe to the body. So as you can see, during the peak of the COVID pandemic, all across the Montefiore health system, since we serve all the Bronx community, we had approximately 2,000 inpatients during the peak of the COVID-19. And this was around first week of April. And then, if you can see, approximately one month after, there was the first reported case of MIS-C was made on May 4. And at that point, we saw a peak in the number of children being admitted for MIS-C in our hospital. And many children found to be positive for COVID antibodies. So there are a lot of hypotheses as to why children are behaving like this. So for example, if we have an infection, we develop antibodies to fight off the infection. So what's fascinating with COVID-19 is that some people survive and some don't. So there's a big question as to why. So the spike proteins that I told you earlier, different people will produce different antibodies. So if the antibody is able to neutralize or bind to the spike protein, then it won't be able to bind to the receptor that I told you earlier. But some people will develop antibodies that is not protective. So it rather promotes the entry of the virus into these inflammatory cells, and then it will trigger inflammation and spread of the infection. In order to understand it properly, this is a very nice diagram of the damage response framework, wherein if the patient is very weak, has a weak immune system, and if the virus is present, it will cause damage to the body. And if the immune system of a person is very robust or strong to the point that it exhibits an exaggerated response to the virus, it will also promote damage. So there should be a delicate balance in order for us to survive. But with COVID-19, we are still learning about it, so there's so many unknowns yet. And we still need to find this delicate balance for survival. So as of May 21st, there were already 180 cases reported to the New York City Health Network, and 90 have met CDC case criteria for MISC. And 60 are still under investigation, and there was one death reported, but the details to this one death are not yet available. So of the MISC cases in New York City, there were 90 cases. Majority of them were from the Bronx, which consists of 34%, mostly from the Black African community and Hispanic Latino community. Majority of the patients were aged 5 to 9 years old and were affecting more male cases than females, which is 54%. So since we are in the Bronx, we are seeing a lot of these patients. And as of May 20, as of yesterday, we have 38 potential cases of MISC. The mean age is approximately 9 years old, but we're ranging from 2 months to 20 years old. Majority are Black, Hispanic, and male patients, which reflects the New York City data. So in our hospital, we were seeing this data is only up to May 24, and at the time we had 33 cases of MISC, and 27 of them met the most common presentation of MISC, which is Kawasaki disease, shock, and heart involvement. And out of this, we had 9 patients with incomplete Kawasaki, and 1 patient meeting the full criteria of Kawasaki disease, and approximately 5 patients coming in with shock and Kawasaki disease type picture. So treatment all across the board, anywhere in the US, is institutional dependent. So you can see variation in the practice, but the main backbone is this should be a multidisciplinary approach, since a lot of organ systems are involved. So in our hospital, we usually call infectious disease, cardiology, rheumatology, critical care for very sick patients. The mainstay of treatment for COVID-19 is supportive care, such as if they come in with low blood pressure, we give fluid resuscitation or vasopressors, and if they come in with shortness of breath and requiring ventilator, then we give support also. So some of these patients come in with shock. As we said earlier, it also mimics toxic shock syndrome, which is an entity where the patient has low blood pressure from the toxins coming from bacteria. So if we cannot eliminate the presence of infection, we start antibiotics also. And some of these patients come in with very elevated D-dimer, which causes increased clot formation. So we also give aspirin or heparin on these patients. So since there is an exaggerated inflammatory response, almost 40 to 100% of New York hospitals give steroids to these children. And all patients with Kawasaki disease-like picture receive the IVIG, or what we call as intravenous immune globulin. This is a pool of plasma from patients wherein it has an increased amount of antibodies so that it will decrease inflammation in children. 5% of hospitals in New York give anakinra, which was originally approved medication for rheumatic arthritis, but it has been shown to decrease inflammation also. So prognosis or outcome, short-term prognosis, there's very limited data based on our experience at the Children's Hospital at Montefiore. All of our children were discharged alive. On follow-up, those with heart involvement, they had improved heart function 8 days after having this illness. And long-term prognosis, we don't know yet, but we have established a PMIS program or clinic in our hospital where children will be seen in that clinic every Tuesday by Peds ID, cardiology, rheumatology, and hematology at once. And they follow up with us 1 week after being discharged, a month after, 6 weeks, 6 months, and 1 year, just to make sure that we are following them properly and that there will be no any other complications. So take-home points for providers and parents. So this is a serious illness, but it's still very rare. As you can see, only a certain number of children come in very sick, but we still should have heightened awareness so that if we recognize, then we'll be able to go to our pediatricians, primary care physicians. But this does not, this is just to spread information. So if your child, you will know that not all children with fever or cough is MIS-C. It could be something else, but you will know if the child has serious illness, because when they come in with abdominal pain, they come in with abdominal pain that some of us think that they have appendicitis because they really have severe abdominal pain. They have really high-grade fever. They have weakness. Sometimes they come in with confusion and rash, eye redness with no discharge. So for our providers, there's really limited information currently, but early diagnosis and treatment of patients and talking with our friendly colleagues will prevent some end organ damage to our children. Thank you.
So we now go to the question and answer section of our program.
Thank you so much, Dr. C, for this very comprehensive guide on pediatrics and COVID-19. The first question I have is, I know there haven't been a lot of numbers yet of cases throughout the world, but what seems to be some risk factors or comorbidities associated with multisystem inflammatory syndrome in children?
So there's very limited data about it because this was just reported April and May, and we are still in the end of May. So right now, we don't know. But the greatest risk factor among these children is being in a place where there is COVID-19 pandemic, like in Italy, Spain. Here in New York, what's fascinating though is that there's no report in China about this rare phenomenon, which is fascinating because there could be difference in when it comes to genetics, demographics, or maybe it could be a different strain of the virus that mutated. I am not even sure if the Philippines has reported cases of MIS-C. That would be interesting to hear.
Yeah, maybe some of our audience members from the Philippines might know that answer. Marie, you have a question as well?
Yes, thank you, Dr. C, for your lecture. My question is, when patients present with shock, is this related to vasodilatory shock or distributive shock, as in sepsis?
So when patients come in initially in the ER, we really don't know what's going on with them. It could be multifactorial because at first presentation, we cannot rule out any form of infection. That's why sometimes we start antibiotics. But what we've learned so far, so we usually give antibiotics for the first 48 hours until we get a negative blood culture and stop. It depends if whether we have a high suspicion of infection or not. But what we've learned is that this is likely more of cardiogenic shock.
Thank you.
Because some children come in presenting with very decreased heart function. The lowest that we've seen so far is 18%. But the good news is that so far, based on what we've seen in our hospital, they usually have some form of heart function improvement within the first 2 to 8 days.
Thank you very much.
Laura, if you could ask your question, please.
Yes. Hi, Dr. C. Thank you for that extensive presentation. You had mentioned that the children who are at risk for these disease are the ones who are in close proximity with the people or maybe parents who have been infected or who have been positive with the COVID-19. And so heaven forbid that these children get infected as well. How soon do you see the symptoms, signs and symptoms? I think you've mentioned that, but I didn't get the exact number of days. And if they are or not, and if they don't get infected, how soon can we safely say that they're out of the woods?
So what we're dealing right now is that we are currently still in the COVID-19 pandemic. So when children come in, it's, to be honest, we admit that it's really hard for us to determine if this child coming in has acute or active COVID-19 infection, or if this child coming in has MIS-C, because they have the same overlapping symptoms. So, but to answer your question, if the child is exposed to a parent, usually the symptoms will appear 2 to 14 days. But then majority of these children have mild symptoms or don't even have symptoms and just present later on as a case of MIS-C. And then when we do our blood work, we see that they're negative with the PCR or the swab, but they're positive with the antibody.
Thank you.
That's a good question.
Thank you.
Great. Emerson, can you ask your question, please?
Yeah, my question relates to the response that you just had. I'm curious if the isolation precaution care that you give to these children are different or similar to adults who have COVID, because you said that the PCR might be negative, but these kids might be positive for antibodies. So I'm curious to know what kind of isolation precaution care that these children receive in patients.
Yeah, that's a very good question. So right now, we still follow the COVID-19 isolation guideline, even if they're negative with a swab, because sometimes there could be sampling error or you just don't pick up the virus. And also, the viral shedding in children based from previous or other viruses tends to be prolonged as compared to adults. But right now we don't know that because we don't have enough studies. So that's why we would like to err on the side of caution and do the standard COVID-19 precaution, which is full PPE.
Thank you very much.
Great. Angelico, Pico?
Thank you again, Dr. C. I guess my question is related to other communities that are not outside of New York. So many other cities in the States, have had their peaks of COVID-19 later than New York. So we might expect that the peaks of MIS-C is also going to be later.
Yeah.
So as many cities are starting to open up again, what advice might you have for parents or general pediatricians in the outpatient setting to kind of watch out for going forward?
So for parents and general pediatricians is to just have a heightened awareness that any child with fever of at least 100.4, at least 24 hours with signs of abdominal pain, diarrhea, vomiting. So most of these children coming in for MIS-C don't have, majority of them have abdominal pain, diarrhea, and vomiting, more of gastrointestinal symptoms rather than respiratory symptoms. And when it comes to school opening, I would be very cautious. Maybe that's why the government decided are still debating whether to open up in the fall because it's very vulnerable and very delicate as of now.
Thank you.
All right. We have a question from the Consulate Facebook page. This is from Susan Gador. It said, Dr. C, thank you for the very informative presentation on MISC. My question is, for those children who tested positive for COVID-19, was contact tracing had been done to determine of how many were exposed and have turned positive to COVID-19 as well as or vice versa?
So our hospital, so what we usually do if we have COVID-19 patients or MISC patients, we report them to the Department of Health. And I am just not sure if the Department of Health is doing the contact tracing right now, but what am I aware is that during the peak of the COVID pandemic, since it's already here in the community and there's community transmission, they were not doing it. But right now, since the cases are trending down, we might start to do contact tracing again.
All right. Now, I have a question also. Now, it seemed like this is a sequela, like a post-viral syndrome in, after the peak of the pandemic, the peak of COVID-19. Do you think that this is just one of many post-viral syndromes that could be possibly erupting from COVID-19?
Yes, that's a good question, definitely. There has been a case report of Guillain-Barré syndrome, which is also a post-viral illness you see in other viruses. So it could just be one or two, or we don't know what's really the long-term sequelae of this disease. And right now we're enrolling patients in a research study just to know what's really going on with COVID-19.
Okay, well, thank you. The other question that I have is, in terms of the IVIG, is that similar or different from convalescent plasma treatment, or is it different?
So there's a difference. So convalescent plasma, these are plasma taken from survivors of COVID-19, and the IVIG is a pooled plasma from a lot of individuals, which there's little difference between convalescent and IVIG. But for convalescent plasma, you know that it came from a COVID-19 survivor, whereas with IVIG, we really don't know because these are like pooled plasma from from thousands of people. So it contains a lot of antibodies from a lot against diseases and viruses, but as to how much antibodies against COVID-19, we don't know, but we believe it helps decrease the inflammation.
Sure. We have a lot of listeners who may not have a medical background, but do have children. So my question is for them. When is it important for us, especially in the Filipino community, call 911 regarding our kids' sickness versus going to urgent care versus staying at home and watching things?
I mean, if that's a good question, because I don't want each of our parents to go call 911 or go to the ER because it's gonna overburden the system. So if they see their child having fever but playing, eating properly, still active, like baseline is still the same, I would call their pediatrician or their local community doctor to discuss the case, and then they can do a telehealth visit with their pediatricians. But if they see their child very weak, not responding, I think that would be different and would probably go to the ER. But I would call the pediatrician in order to discuss properly and in order to triage the system properly.
Great. Thank you so much, Dr. C. We have another question from Dr. Melissa Ada. The question is, what antibiotics have you standardly been using when you see these patients in the emergency setting?
So good question. So it really depends on each patient. So if we see that this patient is coming in from a group home, a nursing home, or from another institution wherein we highly think of MRSA infection, so we give such antibiotics such as vancomycin or higher generations of ceftaroline. But if this child is coming in from the community and no underlying illness, we do empiric treatment such as ceftriaxone. And if we think that the patient has some form of toxic shock syndrome, we give ceftriaxone and clindamycin. So it's really individualized. There's no certain algorithm.
My question for Dr. C is that what would be the best advice for parents upon discharge of the child as far as recognizing the risk of reoccurrence?
Just be very vigilant, and usually when we discharge patients from COVID-19 infection, we advise them to monitor for at least 14 days and to do some isolation precaution in order to prevent secondary spread of the infection within the household. And usually it's been approximately a month or 4 weeks that we see this MIS-C. So just the same, just monitor the child for fever, for signs and symptoms, and then just call the pediatrician or discuss it, do a telehealth visit if she suspects it highly.
Yes, Dr. C, there's a question about risk qualification of patients. It's about which patients, based on risk stratification, are expected to do worse among those who meet the criteria for the MIS-C. Example, higher white count, higher CRP, do worse. So I think she's asking what are those, I guess, things that would be worse for this disease.
Yeah, good question. So what we've seen so far in our hospital is that children who tend to be sicker has higher CRPs. For our community, CRP stands for C-reactive protein. It is one of the inflammatory parameters that we use and trace and trend whether the patient has increasing CRP or not. So for sicker children who are admitted in the ICU, they really have very high CRP, like 20 plus, 30 plus. Or for those children with heart involvement, like myocarditis, they have very high pro-BNP. Pro-BNP or brain natriuretic peptide, this is one of the inflammatory parameters also that we follow, which affects the heart. So some of them have more than 15,000 numbers. When it comes to the white count, it's not a very reliable. So some children have normal white count, some have elevated white count, some have low, but usually normal to low and to high. And then we also see very decreased lymphocytes, or what we say lymphopenia, which is one of the white blood cell.
I actually have a related question to that last question. Dr. C, you had mentioned, you just discussed CRP and white counts. In your talk, you had mentioned elevated D dimers. Could you talk a little bit about the nature of the coagulopathy that you see? And I guess for our non-medical viewers, the nature of things like blood clots and clotting disorders. Is the D dimer just a level, or is there actually associated medical and clinical sequelae from that? And just in your experience, what are some of the things that you would watch out for? As a general pediatrician, coagulopathies are quite difficult to diagnose in children. So what are some, what has been some of your experience in your clinical experience?
Mm-hmm. So based on the adult data, it's been shown that COVID-19 infection is a hypercoagulable state, meaning that people or patients tend to form clots or blood clots, which sometimes can go into the lungs, which make them hard to breathe, or some of them goes into the kidneys, which then cause renal involvement requiring hemodialysis. So D dimer is just a level It is one of the parameters we check and trend to see how elevated or how likelihood that you're going to form clots. So when the D dimer is above 2 in our institution, we usually call our colleagues from the hematology, and usually they start anticoagulation, or what we call in aspirin, which thins the blood. So it's a very delicate balance of everything, as you can see, preventing clot formation, at the same time preventing the patient to bleed. So we have several parameters that we follow, and it is usually a multidisciplinary approach.
Yeah, it sounds like the take-home point is it's a multi-system disease, so therefore it requires a multidisciplinary approach.
Yeah. Mm-hmm.
Thank you very much, Dr. Sy, for a very informative lecture and educating us and our community, the Filipino American community. Thanks you for presenting this. And now we go to some closing remarks from our Consul General in New York, Ambassador Cristobal.
Dr. Sy, we thank you a lot for giving us that really informative presentation. I'm sure parents in our community will be able to recall and to be prepared, watching over their children for signs of MISC, and that's very, very important. Our community, the Philippine American community in the consular jurisdiction of New York, the 10 states in the northeast of U.S., to this day has gathered reports about 94 deaths. That's a sad, grim statistic, but what is positive is so far we haven't received any report of a child, a Filipino-American child, dying from COVID-19. And I hope it stays the same. Another positive thing is that that number, 94, has been steady the past 2 weeks. In other words, our community, hopefully, it's not just we are not receiving reports, but our hope is that indeed no one from our community has succumbed to this pandemic. But a sad thing within that grim statistic is that 40 out of the 94, that's 43% of deaths in the Filipino-American community are or were healthcare workers. 43% of 94. So I thank you all, being frontliners, being healthcare workers, attending to the needs, health needs of the wider community in the New York Northeast U.S. area, and of course also Dr. Moya in the West. But I hope you take really good care, and I wish you all to keep safe in the great work you do for the U.S., for the Philippines, for all human beings in the fight, in the common fight against COVID-19. Thank you so much.
Oh, thank you, Ambassador. Now we go to Dr. Marie Ortaliz to announce the next health forum. By your words, maybe we could, of the ambassador, maybe we could ask a series on frontliners, right, Marie?
Oh, yes, that would definitely be next. Thank you so much, Dr. Romel, for leading this group. And also thank you, Consul General Cristobal, and our wonderful speaker, Dr. Sy, and my co-organizers, To our participants who attended our seminars, please stay tuned for our succeeding forums. It will be announced as far as the most important topics that might interest you. Thank you.
Thank you, Dr. Ortiz. And now, Dr. Laura Garcia for closing remarks.
Thank you all for joining our 6th series of Phil Health Forum. Got feedback? We would love to hear from you. Please send us your comments, suggestions on how we can improve our forum, and most importantly, future topics that you would like to hear. And email us at phil.am.health.forum@gmail.com and follow us at #PhilAmHealth COVID-19. Thank you and see you next time.
All right. Thank you all.